Now you can see, right?
We can see the slides now.
1 second, sorry. Okay, transgastric 0 degrees, another useful view, and as you see, pulmonary valve is at left corner here. Of course, there are 3 important views, and we can say more, because usually we should use modified view, as you see in this case. This case, there was a rudimentary pulmonary valve, very stenotic pulmonary valve, and pulmonary artery aneurysm. As you see here, it's very large and aneurysmatic. But it was possible to obtain this image only just when you are using modified view. On the left side, you see a patient underwent ROS procedure when he was a child, and after many years, it was a degenerative ROS conduit. And on the right side, there was a patient with bicuspid aortic leaflet here, but I couldn't understand what is the pulmonary valve. There was something strange here, but I couldn't understand when I used 2D. Then I obtain a unfast view of pulmonary valve. In same case, I see that yes, this patient has a bicuspid aortic valve, but when I see it, I see that also pulmonary valve is bicuspid, and this patient underwent surgery because of, at the same time, he has a large AST, and surgeon said that yes, it is bicuspid pulmonary and bicuspid aortic valve. And we published these cases because it was the first described case, bicuspid and bicuspid pulmonary valve at the same time. 3D echo has an incremental value over 2D, and beyond guideline, we can say that for now, after technological development. An EMPHACE visualization of pulmonary valve, exact quantification of valve area, detection of leaflet types, and accurate classification of stenosis severity is possible. And on the right side, you can see clearly that this is unicuspid pulmonary stenosis. And as I said before, it is impossible to say when you are using just conventional techniques and 2D echo views. On the right side, again, I want to show you interesting case. This case, I see just a thick leaflets, and I can't understand the leaflet morphology, and I can see unfast view, and there is something in robot face of the leaflets. But please follow the left side, how we crop the patient, how we crop to this image, and you can see a horseshoe shape pulmonary leaflets here because of infective endocarditis destruction of the leaflets. It is really easy to obtain it if you have a good 2D images, but there is a long learning curve. It's longer than other leaflets, and about 100 cases you must do if you want to be an expert of 3D pulmonary valve. 3D, if you want to get a good image, you should do at least 100 cases. You should try it 100 times based on studies. It's not easy, but just you must be stubborn and keep doing. Of course, I wanna share my experience about pulmonary valve stenosis. Yes, it might be valvular, subvalvular, or supravalvular, or together, as you see in this case. This case, you see valvular stenosis and subvalvular stenosis at the same time. But when we use conventional techniques, we use just peak velocity and peak gradient. And of course, it's not enough, because we know that gradient-based classification can be affected by heart rate, volume overload, left, right shunt. So it's not enough to understand leaflet pathology. I want to highlight this opinion with one of very interesting case. This case touched my life because this patient was pregnant, with large ASD and referred to us, and I checked the patient. When I checked the gradient from pulmonary valve, I see that it was severe. It was correlated with severe pulmonary stenosis, and it was 79 millimeter mercury. Okay, if patient pregnant and has severe pulmonary stenosis, we should perform pulmonary valvuloplasty, percutaneous pulmonary valvuloplasty. But I didn't like, because if we do this, it means radiation exposure to baby. So we were in trouble. When I use 3D images, I see that pulmonary valve area is 1.89. So it wasn't severe. And I shared my opinion with our heart team, and I showed the images. Images were very clear, and we decided to follow up this patient. It was really difficult decision for us. And then after delivery, our patient's maximal gradient taken from pulmonary valve reduced to 41 millimeter mercury, and then we perform percutaneous.
1 minute left. Yeah.
Okay, I will finish. And after we closed percutaneously ASD, pulmonary valve gradient reduced to 26 millimeter mercury, and it was correlated now with our 3D measurements. So we say that when we are using conventional method, a misclassification of pulmonary stenosis can be occurred. So we should use 3D images in our daily practice. Also, it is possible to measure not just valvular area, we can measure also subvalvular area as well. Based on our study, we show that when we are using 3D valve area, 50% of patients' destiny can be changed, and we shouldn't trust transvalvular pressure gradient or maximal velocity. We should use FlexiSlice or MPR modes to get right pulmonary valve area. As you see in this case, cut plane must go through the edges of the leaflets. Pulmonary regurgitation, I have 2 more slides. About pulmonary valve regurgitation, as you see in the table, many parameters not defined. So we don't know anything about pulmonary regurgitation. When I summarize all information, I can say that if jet width is larger than 65% of RUVOT, we can say severe pulmonary regurgitation. And you can see this all parameter. I don't want to tell all of them because of limited time, but there is only one study about 3D images, and if a pulmonary regurgitation area is larger than 1.15, we can say severe pulmonary regurgitation. I want to finish my presentation with Isaac Newton words, and he said that what we know is a drop, what we don't know in the ocean, but we should keep going and keep doing to get a good 3D images. Thank you so much.